Go ahead.
Okay. All right. Sorry about that. So the MG activities of daily living, and then there is MGMMT, MGC, and the composite and quantitative muscle myasthenia gravis score and SF36. Again, I won't go through all of these, but the most important one is the MGADL, which we do it in every clinic visit for you when you come in. And some of the questions that you probably heard us asking you is, and this is also used as an outcome measure. What I mean by outcome measure is when they do clinical trials, they're trying to see, does this improve after treatment, with the particular medication. For example, the Vyguard, the recent one, was also MGADL was the outcome measure also that was looked at, and many other studies had MGADL as outcome measure. And what you're looking at is, again, like I said, we ask about talking, chewing, swallowing, breathing, and these are what you experience at home in the last 1 week. And we're asking you, like, does it, the double vision, does it occur daily? Does it occur, is it constant? Is it intermittent? Or is it, does it occur daily but not constant? So these are some of the questions that we ask, and then we come up with a score, and we can look at that every time you come into the clinic, like, and we compare it with the last visit to this visit, and that gives us a little bit of an idea of what's happening, not just in the clinic, but when you say that you're having worsening symptoms, we also look at the MGADL and see, is it changed from the last time? Is it any better from the last time, or is it worse from the last time? That also helps us in determining the treatments for you. So over the years, I mean, we did have, the various treatments that we had, like the negative, the intubation, the giving the negative pressure ventilation, and the tracheostomy, the steroids, and the other medications. This greatly improved the mortality and morbidity for patients with myasthenia gravis. As you can see, in 1960, the mortality, that is the number of people dying with myasthenia gravis, used to be around 30%, but now it's less than 5% because of the improvement in the treatment. So you can see a drastic drop there over the years, from early 19 to 2000, we have a significant drop. However, you see this other line that is going up. That's the line that's telling us this increased prevalence of the MG patients with over the years. And why is that? One is because probably more awareness of the condition, and also being diagnosed more often, even in the elderly population now, which wasn't being diagnosed earlier on. And also, in general, like I said, there's testing, and we have identified more antibodies too. So there is an improvement there, increase in the prevalence and decrease in the mortality with this. And this was the same study from German study, which showed that what were the limitations with MG symptoms. What are the other things that people have reported? They reported like muscle weakness after physical train was the major one. Weakness in the upper limbs was in 70% of the patients, and walking problems, dysphagia, that's difficulty swallowing, difficulty chewing. These were all MG related symptoms that people had reported. Again, some of them may be unrelated, like the sexual disorders. I don't know if that would be related, or other conditions there, like micturition problems, some of them. But overall, like, despite what we are noticing here is, despite the prolonged life expectancy, that is because, right now we have better treatments. Despite this, the quality of life still remains reduced in MG patients. And that's why there is still room for like finding new medications to see if we can improve that. If you look at this physical functioning compared to the normal population, this is 56% had, physical mean was 56, whereas in normal population, that is without MG, was 82%. So the physical functioning is decreased. Physical bodily pain, again, that's general health overall, is decreased compared to the general, the general population, with MG patients. So you can see that overall, despite prolonged life expectancy, the quality of life remains low in this group of patients in myasthenia gravis. So that's why there is importance trying to find better medications or more, that would reduce some of those side effects also. So I would switch gear here and talk a little bit about signs of aging before we go back to how do we differentiate between these two. But there are a lot of signs with aging, as we all know. We do have eyelid droopy eyelids, or sagging eyelids, I would say, wrinkles. Vision problems can occur with age. With again, there's changes in the hair color, there's posture changes, and people have more forgetfulness, memory issues, there's decreased energy. And why do these occur? Because the body is various organs are made of cells, and they're constantly changing. So there is a complex interplay of these. And in early years, what happens is these cells are multiplying and growing. So as the child is growing, there is these cells are growing in the early stage, but later on, in the later ages, there is deterioration of these, and there's various things that influence this aging. It could be genetics. I mean, we see sometimes, people in the 90s, they're still very active, and even at 100, I've seen like people can be like very active. And sometimes it's genetics, they have a long family history. Sometimes it could be the diet, it could be exercise, it could be, the comorbid conditions they have. So what do you see when we say with the changes with aging is like the heart? You have to remember that there are a lot changes in every organ with aging, and like in the heart and blood vessels, the walls of the heart get thicker, the blood vessels get thicker and stiffer and less flexible. And the vital signs, it gets harder to control the body temperature, harder to control the heart rate and blood pressure. Unlike when we were in the 20s or 10s, it gets harder to control these. The bones get thinner and weaker, and joints get stiffer. And in the digestive system, we get slower movement of the food through bowels, and there's decrease in digestive juices. So there's increased problems with digestion. And skin, nails, and hair changes can also be seen with age. Again, this is just a cartoon saying, my bones are getting softer, but my arteries are getting harder. Those are the changes you see in the organs. And so it balances out. Again, this is a cartoon for, just to show that, there's so many changes that occur with aging. Brain and nervous system, what happens in the brain? The number of nerve cells in the brain and spinal cord decrease. Number of connections are the same, but abnormal. People talk about plaques and tangles seen in brain, which are associated with memory issues. And in the muscles, this is important for us because that's where our myasthenia affects. Even with aging, muscle tissue becomes less bulky and less strong with aging. Again, there are a lot of other factors that go into play. Again, if you're not very active in your, in your 50s or 60s, then that can also cause you to have weakness. So you have to be careful. It also depends on the genetics, your exercise, and your activity level. And as far as the eyes, as we remember, like the lens becomes less clear, you can have macular degeneration with aging, so these are some of the things that we may see. So overall, what are the changes and other changes that we see is like people have increased susceptibility to infections. There's slight decrease in the height. Bones can be easily broken because of, again, more falls because of the stoop posture. They have more falls as the bones get weaker. Again, some of it is hormonal. For females, it can be hormonal that the bones get weaker, and we have slowed and limited movement, and overall decreased energy may be part of the aging process. And sometimes people have slowing of thinking, memory, and however, delirium, when we say delirium, like fluctuating confusion and, severe memory issues, these are not part of normal aging. If you have that, we need to, address that also. Reduced reflexes, coordination may be difficult, visual acuity, that is your vision may be decreased, peripheral vision may be decreased with aging, and skin changes can occur. And some weight loss is seen in people due to partly because of the muscle loss. So as you see, there is a lot of changes that can occur with aging. And again, I mean, there are a lot of things we like to do when, but as we get older, we may not have anything, so this is just a cartoon to, again, to say that, again, with aging, we may want to do some things which we may not be able to do. But, again, coming to MG versus aging. So the question is, when you have this drooping eyelid, is this MG? Or is it due to aging? This question is quite commonly asked. Is it just the, so many people have like drooping because of loose skin on the face, in the upper eyelids. So is it that, or is it myasthenia gravis? Again, there are some things that we hear from patients, and we ask these questions is because usually after rest, myasthenia gets better. However, if you have loose skin, like, from what we call as dermatoglossus, it's basically people just have drooping irrespective of whether it's in the morning or in the evening, or anytime they have a constant drooping. And later stages of, I mean, if you have severe myasthenia, you can have that too, constant drooping. But however, majority of the myasthenia patients have better when they just wake up in the morning. They say that my eyes are completely open, and then it gets droopier as the day progresses. And there are other things also, signs that we look at is, are they like folds on the forehead, or on one side where they're trying to lift their eyelids up, or that tells us the muscle is working fine, but they're trying to hold it up. So there are some signs that we look for. And double vision, again, double vision can be due to reduced vision, or like macular degeneration, or cataract formation, like early stages of cataract formation, or it could be something else in the eye that, with aging, we may notice that sometimes. And how do we differentiate this from myasthenia gravis? So usually with myasthenia gravis, that's something which we always ask our patients is, if I close one eye, it gets better, because with myasthenia, it's a muscle problem. So for your eyes to see an object as a one object, your eyes should move together. But with muscle disease, your eyes are not moving. One of them may be lagging behind, and the other one may be moving normal. So when you keep both your eyes open, you see double. But when you close either eye, you see only one. That's usually myasthenia. But if you close say you have cataract on the left side, and you close the right eye, and you still see double with your left eye, that tells me it's in the eye, it's not myasthenia gravis. So these are some of the things. Again, as a patient, it may be difficult for you to realize all that. And sometimes it's, you need I mean, sometimes those are things we look at when you come into the clinic and tell us, like, this has worsened or this has changed. Then we try to assess, is this myasthenia, or is it something else? Is it aging, or is it something else going on? So weakness is a very common symptom that all myasthenics come in with, or even general population, I would say. Generalized tiredness is common with aging, as we talked earlier. Muscles get weaker, muscles get smaller, and we all have like generalized tiredness, and it's more common in aging population. And so I mean, but in elderly population, we do see that. And the MG, the weakness is more in muscles closer to the body than distal, and usually evident on examination. So when we examine you, that's what we are trying to see. And fatigue, again, is something we can't assess always, because people may have normal strength when we are assessing them in the clinic, but they tell us like how it is different at home, like when they're trying to do because it is the fatigue that they experience, like with repeated activity of the same thing that they're doing, they have more weakness. And so one of the ways we assess that is with MJDL, the myasthenia gravis activities of daily living. We ask you, like, when you're combing your hair, do you need rest periods, or do you need some, or constant rest periods, or do you have to use the other hand, like, give the rest to one hand? These are things that we ask on the MGADL. But the other way we can diagnose that, look at the fatigue, is by doing the electrodiagnostic test. That's the repetitive nerve stimulation, where we give repeated stimulations and see if there is a decrement. Like with repeated stimulation, you're fatiguing the muscle, and so you see a decrement, like a decrease in the response. So that's another thing we are looking for in, when we can do that and see whether it is MG or is it something else going on. And difficulty swallowing, again, with aging, like I mentioned earlier, our GI movements are slow, so more problems with reflux can also be seen. So with MG, usually patients have, when we examine, what we are looking for is tongue and cheek weakness. So for someone who's just telling us like they have difficulty swallowing, but everything is very strong, like your muscles of, tongue, your, everything is strong, and neck is strong, usually it may not be myasthenia gravis, it could be something else. Again, myasthenia patients can have other things going on too. Like some patients can have Parkinson's along with myasthenia gravis, or some other condition, and that can cause problems. I mean, I see a lot of patients with the MG also having like pulmonary issues, and we'll talk about difficulty breathing. So this is a common one. Again, I see in elderly population is difficulty breathing. Is it aging that's causing some of it? Is it, with aging, we do have some exertional shortness of breath, especially if you're deconditioned. What I mean by deconditioned is if you're not exercising constant, from if you don't exercise daily, and if you suddenly start walking more, you will feel some exertion, shortness of breath, like difficulty breathing. And also, like, people also have like multiple pulmonary issues as we age. Like we notice, like some people have emphysema, some people have asthma just getting worse, so there are other issues that can occur on top of this. And weight gain, that's another important thing. If you have more weight, there's restriction of chest wall movements, and that also cause difficulty with this. And so usually when we examine, we are looking for weak tongue, facial muscles are weak, if it is due to MG. And if you do a pulmonary function test, that will show that there is decreased inspiratory capacity. That is, when you're trying to breathe in, that force is less. And that's what we test when someone tells us they have difficulty breathing. That is a very good indicator of myasthenia gravis, showing that your respiratory muscles are weak. And the other thing is the weakness, if it should not improve with an inhaler. If it improves with an inhaler, it is not myasthenia gravis. So going on, I mean, it's difficult to there are a few studies that have been done. I mean, this is a paper that has been written by Johan Arley on myasthenia gravis in elderly. Again, what is elderly? What do you consider as elderly? Again, there is definitions. According to the WHO, they say 75 and above is considered as elderly. But again, there is thin line. Is it like again, I think it depends also on our age, what we consider as, elderly or middle-aged or young. But it's, I think, with overall, these are changes that occur over a period of time, like as we age. And difficult, and one of the things that they mentioned in this is it's difficult to diagnose because of other changes due to aging. And more common, thymoma is more common in 50 to 60. And the titin antibodies, again, titin antibodies, like I mentioned, are not being tested right now commercially, but those are more research, but those were more common in the elderly population. And this other study mentioned that people over 75 who have MG, usually they have a benign course with low rate of respiratory crisis and rarity of thymic pathology, and can control adequately the symptoms with low low amount of medication. So I think this seems positive. However, I think we need more data to really say, like, is it any different from younger to elderly population? So the important thing, I mean, I told you all about like aging and MG and how to differentiate some of the signs. However, you have to remember, like, again, not all changes are normal in aging. Again, we don't want to attribute everything to just say, oh, that is aging. I don't want to say that, because we want to actually examine, and that's what we do in the clinic. We try to examine patients when they tell us, like, this, do you think this is related to aging, or is it related to my myasthenia gravis? That's why we are here to examine, and there are many misconceptions of what is normal part of aging, and that's why it's important to talk to your physician. And anything that you notice, any changes, just talk to your physician and let them know this is happening. Is it aging, or is it due to myasthenia gravis, or it could be something else going on, and because even cancers are common at that age, and so we just want to make sure that it's not something else going on. So, and if it is necessary, they may refer you to another specialist. And treatment wise, again, we can't change the genetic constitution of a person. However, we can stop cannot stop the passage of time. Like, we cannot stop the aging process. I wish I could say there is a magic pill to stop and treat that. However, the things that we can change are the lifestyle, being active, reduce the risk factors of some of the other diseases and conditions, like, with age, people develop high blood pressure, diabetes, and, heart conditions. These all, with lifestyle changes, you can prevent those. And also, like frequent screening and immunizations, these all help prevent diseases with screening. So, I mean, coming back to my first case, I would say, in that person, because the examination did not change, I would say it's probably related to the infection, like because the person had recently COVID infection, any infection, people have tiredness after that. And some people may have longer duration of tiredness than before. What I like to, I mean, it's good that they are talk to me about the weakness, because then I examine them and make sure that the symptoms or signs did not change from the prior examination. So the examination 1 year ago was the same as now. So I know that nothing changed as far as that is. But if they still say that they're having symptoms, the other way I would test is with an electrodiagnostic testing to see if there is decrement. But you have to remember, any kind of infection or any kind of, like, with aging, we do see some changes, but always talk to your physician to make sure that it's not related to something else going on or MG worsening. So, any questions? Thank you for giving me this opportunity again, Allison and Meredith, and I'm open for any questions there.
Wonderful. Thank you so much, Dr. Pasnoor. It looks like we have a question. Simple question, since someone is relatively new to MG these last 6 months. Can you explain what antibodies mean? Sounds like a pretty, we toss that term around a lot with myasthenia gravis. So could you maybe just enlighten us about the term antibodies?
So, yeah, that is a good question. I think Mr. Case asked that question. It is a interesting, it is an interesting question. So what happens is, our body has some defense mechanism. So when some foreign body or an antigen, or for example, the COVID, when we talk about COVID, it's a foreign body to our system, like, the virus itself. When it comes into our body, we have a defense mechanism. Some of our macrophages, our blood cells, attack the virus. So instead of attacking the virus, there are some antibodies that develop in our body that are attacking our own body system. So they're attacking the receptors at the junction, post-synaptic junction, in the muscle that I've showed, the initial picture that I've shown. So those antibodies are what we are talking. So, I mean, just like we have antibodies, like for myasthenia, we call those as acetylcholine receptor antibodies, because these are attacking mainly the acetylcholine receptors. And MuSK is another, which also is attacks somewhere near the neuromuscular junction. So that is another antibody, and LRP4 is another antibody. So you have to realize that acetylcholine receptor antibody was, known for many years, but LRP4 and the MuSK has been identified later on, and we don't know how many more are there that for myasthenia that could cause myasthenia. And that's why we have this group of seronegative where we may not find an antibody, but they still have myasthenia symptoms and signs, So we make that diagnosis based on other tests like the electrodiagnostic test. And for COVID, again, we are talking about COVID antibodies. When, just like I mentioned, when the virus comes into your body, there are the defense mechanism against that virus, and those are the COVID antibodies. And we can test for those antibodies also in the blood. We can test for the antigen as well as the antibodies. I hope I answered that question.
Yeah, no, that was great. Thank you. Couple other questions. Do we know why some skeletal muscles are impacted and not others, i.e. ocular versus generalized?
Yeah, that is an excellent question. But again, scientists have wondered about it for many years, and we don't know why that happens and why it affects some people just in the eye and some people more than the eye, and why does it progress. So I have to say, we don't know that answer, and I don't know if what specific test would really help us with that, because it's not any different in the structure, but these are all skeletal muscles. So it would, at this point, we don't know the answer.
That's a good question. It's something I never really thought of, but a really good question. Okay, so one more it looks like, and please, if you have any other questions, please feel free to keep them coming in. But it sounds like a patient went to see their physician the other day, and they said they were glad to see this person's MG was still in remission. It was 2 years ago in August. They were wondering later, because of the way this physician said it, whether MG symptoms always come back in your experience.
So that is a good question. Again, MG is, no one knows the natural history of MG. We know that it fluctuates. We know that, we have better treatments now. However, we don't know whether, like in some person, will it come back after 1 year, or will it come back after 2 years, or will it ever come back? Because I have patients who have MG like mild symptoms like 10 years ago and don't have any symptoms now, or some people who have constant symptoms since I've seen like for the last 5-6 years, the same symptoms, so it is a good question. But again, like I said, we don't know the natural history. It can fluctuate, whether it'll come or not, it'll be hard to predict that. And and that's one of the reasons why we follow our patients. Also, if they're very stable, we follow like once a year. If they're having symptoms, we follow every 6 months, or if they have more symptoms, we follow more closely. So to your question, Debbie, I think basically we don't know the fluctuations when it can happen. We don't know the natural history of MG.
Yeah, great questions. These are really thus, even though I've had myasthenia for 15, 20 years, it's always new questions and good to ask. Any other questions? Let's see here. In respect to some of the aging issues, digestive, should the primary care provider or neurologist manage care? That's a good question. I feel like, especially just with myasthenia, I'll speak, this wasn't my question, but I'll speak to this too. It's like, you have issues maybe not related to myasthenia but I feel like they always default to the neurologist. So what are your thoughts on that, Dr. Pasnoor, about aging, specifically digestive? Who manages that, or how do you guys approach that?
Yeah, I think it's an important question, and thank you for asking that. Actually, we get that question all the time in the clinic. Unfortunately, I have to say, being a neurologist, again, we may not be well versed with all the treatments of what they would do or what kind of tests they would want to do for the other digestive issues, so I think again, if it's related to, it's okay to ask us, because then we know whether it's related to MG or not, and then we can assess that and then let you know specifically, like see your primary physician for this issue, or see your gastroenterologist for another issue, or your cardiologist. Basically I think it's okay to ask us, but I think it would be good to follow up with your primary physician if you already know that it's not related to MG.
Great question. How often should we still do a bone test? Excuse me. How often should we still do a bone density test every so often, even though we haven't been on prednisone for quite a while? Another good question.
Yeah, so actually, I mean, normally the bone density scan, we do it only if patients are on prednisone. And that is, again, if it's low dose prednisone, I do it every other year. If you're on high dose prednisone, you may need it every year. However, if you're not on prednisone, then it depends on what your primary care physician would like to do. And I think Medicare pays for every other year. However, I think if you have osteoporosis, they may want to do more frequently. If you don't have osteoporosis, they might do less frequently. Again, that would be something your primary physician would decide, like, when to do it. But if you're not on prednisone, I mean, neurologically, you don't need it for, as a routine. You don't need it from the neurology standpoint, but definitely from, having menopause, again, people will have like hormonal changes, and that needs to follow up to make sure that the bone density is not decreasing based on that. So it depends on whether you have osteoporosis or decreased bone density or not.
Really good questions. Any more questions? Feel free to keep asking. We got a great expert on our hands. So any other questions? Okay, let's see here. Another good question. Is reasonable exercise appropriate for MG patients with muscular issues? And would it be more appropriate earlier in the day?
So that's a great question. Actually, I'll be talking about exercise also with the MGFA next month, I think in 2 months. But, exercise, people always worry about exercising when they have MG. But I tell my patients, that with MG, it doesn't restrict you from exercising. You should continue doing your regular exercises. Again, if you're feeling too tired, then back off and give it a little break and then continue again. Obviously, if you're having an exacerbation, like say, for example, you're having a difficulty swallowing or breathing, I wouldn't recommend you doing exercises at that point. Then I would say, like, let's, take rest and get that managed. And then once you're stable, you can do any exercises, I would say, as long as you're not getting too tired. Again, even sometimes with myasthenia, if you're doing continuously, you may feel tired. So I would say take some breaks and continue again. Some people may need only like 5 minutes exercise, take a break and do again. Or, if you're strong enough and are able to do more than that, that's okay. So I would just say, I wouldn't restrict you from doing exercises if you're stable.
Any other questions? Let's see. Does blood type matter when considering, I'm assuming IVIG is the question? IgG?
No.
IVIG. Does blood type matter?
No, it doesn't actually with the IVIG, because we're taking the plasma of that. So no, to the question, no, it doesn't matter. Those are all very interesting questions, actually, very good questions.
Yeah, these are great. Really good. I do have a question for you. It's maybe not necessarily related to aging, but can myasthenia gravis patients donate blood?
Yeah, that is interesting. I mean, that is a good question. And, I have to say, again, with the antibodies, Meredith, I don't know that answer. I have to get back to you on that.
No, that's okay.
I think someone asked me this before and I forget. I know I looked and saw, like, I know with the antibodies, probably not is my answer.
yeah,
But
that's what I would think. But nevertheless,
that's probably not, because again, just like in mother, like passing the antibodies to the baby, you worry
right,
about that.
right.
Placental,
I,
transplacental, transfer. So my answer would be no, based on that.
Dr. Pasnoor, I looked it up this week as somebody asked
Yeah,
that question on our Facebook page. And the Red Cross says they have a disclaimer that no.
yeah.
But I didn't know if it was just them or case by case.
Yeah, I think no would be the answer, because I mean, with the antibodies being present, I mean, you don't
Right.
want you to give those antibodies to another person. So
Gotcha. Thank you. Any other questions? They're all very good questions. Alrighty, well, in that case, I guess we will go ahead and wrap up. Thank you so much, Dr. Pasnoor, for presenting to us today. We are always so grateful for your expertise and knowledge, and once again, another great presentation. So, oh, looks like, do we have more questions coming in? Can we ever decrease our steroids?
yes, that is a great question. That is the goal actually for most of us. The literature shows that if you're 10 and below 10, it's okay. However, if you have other side effects from that, if you're having, say, for example, osteoporosis or bone density shows low, we definitely want to get you off of steroids. And, that is one of the reasons why we are trying to find new medications, is trying to reduce the side effects of some of this. I mean, steroids are great. I have to say, I mean, they really work fast, and, faster treatment, and an easier accessibility and less expensive and all that, but they have a lot of side effects too. So usually we start off on steroids, but try to taper you off, or try to get you at least below 10, so that if you're just on 5 milligrams and that's the only medication you're on, it's probably okay, as long as your bone density is not changing. But definitely, I think, there are a lot of people who are not on steroids. They are not on any medications, I would say. So it can be not, you don't have to be on steroids, but your physician will work with you on trying to decrease that. So just have to work with your physician on that.
Right. I know it's the nature of the beast with prednisone, right? It's such a good drug, but it comes with a lot of, side effects. So when on Solaris, do we know how long will you need to stay on it? It's a tough question, I presume, but
actually, I mean, the studies have shown that at least you need to be, again, when you ask that question, I don't know if you mean like, how many months to see the benefit, or if you had a benefit, how long to be on it. So I'll answer both those questions. Usually it takes about, I would say, at least 3 months to say, like, whether you have benefit or not. I wouldn't stop it at the first treatment and say that there's no benefit, but usually we say, like, stay on it for 3 months, and if you don't have benefit, then you just go off of that. But however, if you're having benefit, again, it depends on your symptoms. It's hard to say when you're going to get off of it. If your symptoms are stable, or if your symptoms are completely resolved, then we can try usually your neurologist, or I usually try to taper that or space it out and see if you're still having any, I mean, if it's still stable, then we can try to get you off of that. So it's hard to say when, how long. That's a difficult question, how long. It depends on individual person. Some people may need it only for a few months, some people may need it for years. So it depends on you.
right. Good question, though.
Good question.
Anybody else? As always, too, you can always email Allison or I or info@mgakc.org with any questions, and I'm sure Dr. Pasnoor be happy to relay answers back to us as well. But thank you again, Dr. Pasnoor, as always, receiving such positive feedback already. So thank you again for taking your Saturday morning to sit with us and share your expertise. It's so valuable to our community, and we are so grateful. Allison, do you have any last words?
I echo all those wonderful statements that you said, Meredith. Thank you so much, Dr. Pasnoor. We really appreciate it.
Yeah, and thank you for, allowing me to present this. And thank you all for being on this morning on Saturday, and go Chiefs tomorrow.
Yeah.
I'm sure all of you are waiting for that, and, have a wonderful rest of the day. And thank you, Meredith and Allison, and you guys do a wonderful job at, getting all this together. Thank you.
Thank you. Bye,
Thank you so
everybody.
much. Bye, everybody. Take care.
Peace.